So next, he's introduced me at a few CAGLA presentations, so now I get to return a favor. So our next speaker is Robert Vasquez. He's a partner of mine, colleague, and well respected in multiple areas. So he started our AYA, or Adolescent Young Adult multidisciplinary clinic, the only one in the state at Ochsner, as well as he's also our bone marrow transplanter, and we're growing that program as well. So thanks for giving the next talk.
Okay, before we start the talk, I just want to have a few definitions. You probably all know these, but I always like to make sure that everyone does. ALL is acute lymphoblastic leukemia. For the most part, for about 90% of this talk, when I talk about ALL, I'm going to be talking about B-cell ALL. I'll throw in T-cell a little bit at the very end. AYA, adolescent and young adults. So the NCI defines a young adult as aged 39 and between ages 15 and 39. So yeah, as a pediatrician, I am actually seeing some 35, 36-year-old patients. PH-like is Philadelphia chromosome-like. It's a bunch of mutations in signaling pathways that are similar to something called the Philadelphia chromosome, which we'll be talking about in a little bit. And then MRD, which Dr. Blue talked about a little bit. That's minimal residual disease. It's however you measure it and whatever disease you're talking about. So why is a pediatrician talking about treating 30-year-old patients? Because ALL is a pediatric disease. The highest incidence of ALL occurs in kids between the ages of 5 and 10. So pediatricians are good at ALL. Right. Now, let me ask you, everyone except for Corey, and yeah, and you two can't answer this. You have a 5-year-old right now with newly diagnosed ALL. What is the percent survival for that kid? What was that? About 95%, which is pretty extraordinary. Now it's working. Okay. Okay. Given that when I was born in 1964, everyone with ALL died. Right? So within my lifetime, we have seen ALL go from a disease where all the kids died to one in which 95% of the kids are cured of the disease. If you look at that on the left, right, you see that the real kind of big initial advances were in the late 1960s and 1970s. That was when combinatorial kind of chemotherapy came into play, and a drug called asparaginase was introduced in the 1970s, which made a huge, huge difference in the treatment of ALL. Since the 90s and through now, we've made incremental advances. So we've gone from cure rates of the 80s to up to the high 90% for most ALL patients, which is kind of extraordinary. This is fiberglass. Those kinds of advances were not seen in the adult population. And what's interesting is anecdotally, pediatricians were sometimes seeing 20, 22, 23-year-old patients, and they'd come in and they do pretty well with us, right? Then when in the adult world, the survival rates weren't like that, right? And unfortunately for us, pediatric hematologists and adult hematologists don't speak to one another very much. In fact, even worse now, mostly we're on different campuses, with the children's hospital sometimes being in a different city, different part of the city, and sometimes a different state than the adult hospital. So advances that happen in one don't necessarily translate to the others. And for these people that are in their late teens, or 20s, and early 30s, really would be beneficial for us to play together, because it turns out that that population sometimes has diseases that are a lot more similar to our kids, sometimes more like our adults, sometimes a hybrid of the two. So traditionally, up until relatively recently, if you went to see an adult hematologist and you had ALL, you were getting hyper-CVAD. It kind of was the standard. It's what they've been using forever. And it didn't work all that well. I'm sorry to anyone from MD Anderson who might be here there, because some of them still hold on to that, but the cure rate for it in most centers was not very good, as opposed to what we use in pediatrics. So in our high-risk ALL patients, here's a plug out to international. The Germans developed it. All right, the protocol is called BFM, augmented BFM. BFM stands for Berlin, Frankfurt, Munster. They gave us that. Then about 12 years ago, there was a real game changer. So the photographs in that picture are two people who are really important to my training and really actually important in AYA oncology as well. So Wendy Stock is very well known in the field. She's an adult oncologist, adult hematologist, who has championed and made huge advances in the treatment of both adult and AYA leukemias. The gentleman over there next to her is Jim Nachman. Jim Nachman was a pediatric oncologist at the University of Chicago. Jim and Wendy used to argue all the time, right? Jim would say, Wendy, you guys are treating ALL wrong, right? You just are. My 20-year-old patients do great, yours all die, right? Well, Wendy took that to heart, and she decided, let's see if that's true. So she organized a national study where they compared pediatric therapy to historical controls using hyper-CVAD. And the cure rate in the pediatric style therapy group approached 70%. It was like 67% compared to 35% with the historic controls. That's pretty significant, right? Then the difficulty came getting the word out. So trying to translate that therapy into the adult clinics. Adult hematologists hate pediatric protocols. Right? We have different phases of therapy with different drugs given at different doses, and it just blows their mind. They just don't like doing it, right? So asking them to start treating their young adult patients this way was kind of difficult. And then getting those same patient populations into pediatric clinics was kind of difficult, right? So over the course of the last 10 years, we've done pretty well at educating people about saying, yes, these patients will benefit from pediatric style therapy, and the field, which is now really truly becoming a field of AYA oncology, has grown. But a lot has happened in the last 10 years. Okay. So for the most part, I would say most centers have adopted using pediatric style therapy for the AYA population. We've had 25 studies since that time that show that this therapy is superior. A meta-analysis of 11 different comparative studies showed that the event-free survival was definitely superior with pediatric style therapy. However, when you're adapting this therapy that was designed to give to 10-year-olds to a 35-year-old, there are some real issues. The toxicities are different. I would say somewhat worse. And so developing expertise, and mostly by trial and error, giving these therapies to those patients, you have to know what to look for. For example, thrombosis risk is much higher in our older patients in general than our kids. Pancreatitis is more likely to happen in a 37-year-old than it is a 5-year-old. And knowing how to adjust dosings of things like asparaginase, right? So giving the 2,500 per meter squared that we give of a kid, I wouldn't do that to a 35-year-old, right? So what dose to give? We're still not completely sure, but we keep playing with it and we're getting better at it. So this was just published a few years ago. This was showing that even compared to transplant, so when I came to Ochsner 13 years ago, and the adult hematologist would refer patients to us to take care of their ALL, standard of care would be that they would get hyper-CVAD and go to transplant if they came in through the adult side, right? They would come to me and I would say, no, we're not going to do that. We're going to try this therapy and hopefully avoid transplant. They did a separate analysis from the data that they had from the study that I was talking about, where it compared patients who did go to transplant versus those that just received the chemotherapy. And you can see that overall survival, event-free survival, were higher in the patients who didn't go to transplant. And of course, non-disease mortality was higher in the transplant arm. And in the last few years, we have some new agents that have changed the landscape even more, these targeted therapies that I'm going to talk about. Right, B cells are easy. They have a lot of different markers on them that we can use as targets for drugs, and we have done so. One agent you've heard about a couple of times at different meetings is blinatumomab. Blinatumomab is a really cool antibody. It binds both B cells on CD19, and then it binds T cells, brings the T cell into close contact with the B cell, and the cytotoxic T cell destroys the B cell. Really, really nice drug. Again, shout out to the Germans. The first study for blinatumomab was done in Germany in relapsed ALL. They took patients that had been treated multiple treatment failures, and showed that as a single agent, blinatumomab induced a number of remissions. It's the way we trust new drugs, right, in patients who've already failed everything else. Since that time, multiple papers have shown the efficacy of blinatumomab in the relapsed ALL population, and it is FDA approved for relapsed ALL in both adults and kids, and now for upfront therapy for both populations as well. But now I want to tell you about a trial that actually just published its data last year and is a game changer in terms of practice for ALL. This was an adult study. Patients aged 30 to 70 were enrolled. They received a backbone of chemotherapy that was sort of our augmented BFM with a little bit of difference. They threw in some etoposide that we don't usually do, and they did cap asparaginase, but it was overall a backbone that was sort of a hybrid of the two and very well designed. And they randomized patients to receive either 2 cycles of blinatumomab or chemotherapy alone. And they saw that the overall survival rate at the, 36th month, I believe, was almost 80% with blinatumomab. This is the backbone of the chemotherapy. But anyway, that data was so convincing that is now a practice changer. So adolescent and young adult patients with ALL, recommendation is that they receive at least 2 cycles of blinatumomab in a backbone of chemotherapy. If they are MRD negative, they don't go to transplant. So what about for our relapse patients? We have an open trial right now I'm just telling you about because I think it's really cool, which uses chemotherapy-free therapy for our kids using nivolumab and blinatumomab. That is still accruing. We don't really have any data on it yet, but it's looking promising. As more standard kinds of therapy, inotuzumab is another one of these antibodies. Inotuzumab is a little bit different than blinatumomab in that it's linked to a chemotherapy agent. It binds to CD22, which is another one of those receptors on a B cell, and it delivers the chemotherapy directly to the infected cell. Inotuzumab, like blinatumomab and all of our drugs, was first done in the heavily pretreated patient population and was shown to be efficacious, and then was incorporated into larger studies for relapsed patients and was shown to be very effective as a single agent. So much so that our last still open COG study incorporated inotuzumab in the study. However, that arm of the study got closed when the blinatumomab data came out. So we actually had to stop, say, okay, we're not going to do inotuzumab now for these patients. We're going to give them blina. If they've already gotten inotuzumab, we're going to still give them blina. So that's a study that we still have open for COG for the relapse refractory patients. Now this is interesting. Adult data from a very small study from the Alliance Group, which is actually chemotherapy-free treatment of ALL using both inotuzumab and blinatumomab, and it was looking really promising. It's in a very small patient population, they only use 30 patients, but the response rate was greater than 90%. Early data, but I think this is where we're heading. I think that's where we all think we're heading, is to go to chemotherapy-free treatment of this disease. Okay, let's skip that one. So now let's talk about Philly chromosome positive ALL. That used to be a really bad actor, even in the pediatric world. If you had Ph positive ALL, it wasn't good. The Philadelphia chromosome is a translocation between 9 and 22 of the BCR-ABL genes. I'm not going to talk about Ph yet, because sorry, I'm going to come back to that. So in kids, we did a trial a few years ago where they published the data, and we amplified chemotherapy for these Ph-positive kids. Right? We added toposide, more Cytoxan. It's quite aggressive chemotherapy, but the cure rate was great. Right? The cure rate was, I think, approaching 90%. Just a few years ago, however, out of the MD Anderson group, they published using blinatumomab and a TKI for patients with newly diagnosed Ph-positive ALL, and they saw an amazing response rate. Right? The question still remained, would the patients stay in remission or would they have to go to transplant? And adult leukemia doctors in general like to take patients to transplant. A subsequent study done at MD Anderson then expanded this in a larger patient group and using a third-generation TKI with blinatumomab saw really impressive results, and these patients did not go to transplant. So it does seem like at least most patients with Philadelphia chromosome positive ALL may not need transplant at all. We still haven't accepted that in pediatrics. We're working on it. And then pH-like mutations. pH-like mutations are a number of different mutations in different pathways that look like the Philadelphia chromosome. Right? We know that those ALLs tend to respond less well than our ones without those mutations. So recommendation for those is to treat if you have a target mutation in the pathway. So in the pH-like pathway, you can use a tyrosine kinase inhibitor in addition to chemotherapy. And then CAR T, because everybody is talking about CAR T these days. So CAR T for ALL was the first CAR T. The first patient was a girl at the Children's Hospital of Philadelphia who had multiply failed. She had had transplant twice, I think, and was dying. And so it was a last-ditch effort. The treatment was successful. She's still alive. In this case, CD19 is the target. And I won't go over this because we've already talked about it. But we now have 2 FDA-approved CD19 constructs, interestingly enough, and really frustrating, actually, for those of us who did AYA oncology. The first one was approved for kids up to age 25. That never happens. There has never been a time where I've had a drug that was approved in kids that I couldn't use for my adult patients. Right? Happens the other way all the time. Right? So I would have a 26-year-old and be like, oh, I can't give you this, right? Fortunately, now we have a CD19 that's approved for patients who are over 25. They're slightly different drugs, still the CD19. There's the Kymriah, which is trisglut, and then the bruxglut. Interestingly, when they did real-world comparisons of these, they're actually seeing in the patients that were eligible for both that in these AYA populations that the brux cell might be more effective than the tris cell in this population. I'd say we still need more data on that, but that's the way it's looking right now. We also have in development CAR Ts for CD22, for combined CD22 and CD19. All of those are pretty far along in development and may be hitting us in the clinic relatively soon. Now, I told you I'd talk about T-cell ALL for like 1 second, right? T-cell ALL, historically, before the advent of augmented BFM in the pediatric world, had a worse survival rate, right? Augmented BFM changed that. We used to say even before a few years ago that the outcomes were pretty much the same. And then we did a trial looking at a drug called nelarabine and adding that into the backbone of our therapy. And the addition of nelarabine into our augmented BFM protocol in this children's oncology group study, ALL 0434, increased overall survival to 91%, right, from 84%. So yeah, if you have a patient with T-cell ALL, they should get nelarabine and pediatric cell therapy. So who to transplant, right? Comes up with us, you guys and us all the time. So who to do it, right? Seems to be constantly changing. In peds, we really don't consider transplant in CR1 for almost any patient. It's very rare to take a patient in first remission to transplant. In young adults, if they have a Ph-positive ALL and they didn't respond and they were still MRD positive at the end of induction or consolidation, I would say, therapy, you might want to consider transplant. Or CAR T, if you can do it. Or CAR T and transplant, which we are now also doing. And even with these newer therapies and the kind of more widespread knowledge about the fact that pediatric protocols work better than adult ones, these survival disparities seem to still exist. If you are a 25-year-old and you're treated at a center that has an AYA program, outcomes seem to be better than if you're treated on the adult side, right? If you're a 25-year-old and there is not an AYA center, you tend to do better if you're treated by a pediatrician than the adult center. That seems to be holding true across the board. Some of it's to do with the therapy, some of it's to do with knowing what to look for the toxicities for the therapy, but some of it probably is also the kind of psychosocial support and the approach to that age patient, which is, a lot of 25-year-olds are a lot more similar to our 18-year-olds than they are to the 60-year-olds that are more typically coming into the adult clinics. And so our supportive care may help them a lot more. So for an AYA patient with newly diagnosed B-cell ALL, enroll in a clinical trial. If they're either a pediatric or adult cooperative group, one of the exciting things is over the last few years, the pediatric and adult groups have been talking a lot. And so we're having trials that are actually covering the continuum rather than having one trial in the adult world and the other in the pediatric world. Refer to a center that has an AYA program, or if a young AYA to a pediatrician. Provide age-appropriate supportive care, things like fertility counseling, psychosocial support, and treat with pediatric or AYA-specific therapy, as these are translated in significantly better outcomes for these patients. And now we can say incorporate blinatumomab into therapy for B-cell ALL. And if a pH-like mutation, consider adding either a TKI or a JAK inhibitor to the therapy. If MRD negative after induction or consolidation, transplant not indicated for most patients. So the take-home message, we've made unbelievable progress in the course of my lifetime in treating this disease. And now a majority of young adult patients with ALL can now be cured, many without having to go to allogeneic transplant. And the future is the immunotherapy that we're seeing, right? We're moving increasingly to CAR T and antibodies rather than traditional chemotherapy, and that's good for everybody. Right. Questions? Thank you.
We're going to limit to one question, just we're a little bit behind, so one question, anybody? It was that good. All right.
Yeah.
Thank you, guys.